Hey everybody, it's Dr. Wood, and today I want to talk a little bit about ethics in research. So, when you get your white coats, something that you're going to be doing is you're going to be saying the Hippocratic Oath, right? So, this is something that almost all healthcare providers, but especially you providers, are going to be saying to say that, hey, like, we're going to take the patient's best interest at heart. We're going to make sure that we do no harm, all of that, right? So, very important oath that we take to make sure that we are very ethical, to make sure that we have integrity, and all of that. Well, how does this apply to research? Well, one of the things you're going to find is that for most organizations, they will have what they call an institutional review board, or the IRB. You've probably heard me mention this before. This is something where it may be a hospital-based IRB. It could be a school-based one. So, for instance, NSU has their own IRB housed down in Fort Lauderdale. And basically what they're designed to do is to make sure that they review every piece of research that's going on under their purview to make sure that the human subjects that are involved in that study make sure that their rights and their welfare are being protected, right? So they review all the study protocols that come through, even if it's as simple as a thing as, you're just looking at charts, that have been, it could be 15 years old or something, charts you're looking at. They still have to make sure that you're doing things like protecting anonymity. They have to make sure that everything is being done appropriately and ethically, right? And again, they are not there to say, well, you shouldn't be doing this. They're there basically saying, like, okay, here's how we can help you to design your study to protect your human subjects, whatever the case may be, whether or not you actually have direct human interaction or not. And so we'll talk more about those details in just a moment. So there's this BELMONT report that's out there, and basically they set up a lot of the guidelines for research. And so these are the basics of things you want to think about. Say you were, for instance, trying to write the conclusion to your paper, and you're trying to think, okay, how would I design a study that would answer the question that I'm actually asking here? Because you might not find the perfect study out there for your paper, but if you're saying, okay, well, how should future researchers do this? These are some things you want to think about it from an ethical sort of standpoint. So first off, they say you have to have respect for persons, right? So what this means is that no one can be coerced into participating in a study, right? So people are autonomous, meaning they have their own agency. If they don't want to give you the time of day, they are under no obligation to do so. That also means things like informed consent is really important. You can't just say, hey, be in my study, it'll be good for you, trust me. That's not great. You have to go through and actually talk about, here are the risks, here are the potential benefits, here is how the study is designed, etc., to make sure that the patient has all the information they need to know to make an informed decision about whether or not they want to consent to being in the study, right? That also means that voluntary or the participation is voluntary, as I mentioned, and they can leave the study at any time for any reason, right? There's no means for you to keep someone in a study because they are autonomous, right? So if someone says, wow, the side effects from this drug are just too much, I just don't want to be in the study anymore, they can do that, right? And they can walk away. And researchers have to account for that with things like intention to treat analyses and attrition rates and all of that. It's a pain, but you have to do it. And then also you want to make sure you're maintaining privacy. So HIPAA is really, really important for this stuff. Frequently when we're doing IRB proposals, we have to do things like talk about how we maintain the privacy of the information, right? We make sure we're following HIPAA and all of that. So you have to talk about things like, okay, well, the only digital copy of the patient charts are going to be kept under lock and key in this particular office. And you have to do that because if it were to get out there and you lose people's private information, that could be really bad from an ethical standpoint. So don't do that, right? Next is this topic about beneficence. Basically, we want to protect subjects from harm or undue harm, as the case may be, even though you may be performing a study and you're looking to see what the outcome of death is potentially, but you're not going to be the one that is going to be putting that patient into undue harm. So overall, you have to design the study to make sure you're maximizing the benefits that the patient may get while reducing those risks of harm. And frequently that helps to inform research design. So especially when you're thinking about the question of like, well, what is going to serve as a control group, right? So if I was designing a new HIV drug and I wanted to figure out how effective it is, so I have my intervention group, they're getting this new drug. Well, who's my control group? Do I just give a bunch of patients with HIV placebo? Well, you can't do that because that is maximizing harm for them, because we do know what we do know from the studies is that treating patients with antiretroviral drugs is a good thing for them. They live longer, they have healthier lives, right? So in those cases there, you have to use maybe a gold standard as your control, right? So we're going to say use standard HIV treatment regimens, heart regimens for the control group, and then we'll have this experimental group getting this new drug, right? You've maximized the benefits while reducing risk of harm for those patients, right? Now, could that new drug be potentially really toxic and kill people? Maybe. Hopefully they've done enough preclinical testing to know that, but that is a risk, right? But we don't know. That's why we're running the study in the first place. You also want to make sure you have competent investigators. So for instance, if you're doing a study on orthopedic procedures, you don't want to have someone who is, say for instance, endocrinologist. Like that wouldn't make a whole lot of sense because the two are just not really not a lot of crossover there. So you want to make sure people are competent to perform the investigation. And then again, looking at favorable risk versus benefit analyses here. So this kind of goes back to maximizing the benefits while reducing harm or risk of harm to the patients there, to make sure that, again, we are trying to mitigate as much as we can for these patients while still being able to perform a study that is scientifically valid. Next is justice. It's one of the other next big headings from the Belmont report. And basically what this means is that the benefits and burdens have to be spread equally amongst all participants in the studies. And so one of the big things that this has some specific points for, it includes at-risk populations, right? So these are people who are at high risk for harm from different types of therapeutic interventions or different types of studies, or they may be patients who are, say, not able to give consent, right? So they may be people who are either unduly motivated to join the study for some kind of potential benefit. They may be people who are unable to give consent, and then ethically it just gets pretty dubious at that point, and you just can't do it. So, for instance, when you're looking at a lot of pediatric information, especially about drugs, it's hard to do studies in children because children can't really give consent. If they're less than 18, you have to involve their parents, and there's this idea of assent that the children have to give, assuming they're of an age where they can actually process that, hey, I'm being put into a study. That gets difficult. Obviously, prisoners, people who are actually incarcerated, they are a group of people who are at risk already. But again, think about it, if they think, oh, well, maybe if I participate in this study, maybe it's going to help me out and get out of jail sooner or something. That's not great. So you can't really do that just because they are a captive audience, so to speak. So prisoners are usually one of those really at-risk populations we don't do it with. Obviously pregnant females, because the fetuses can be directly affected by some of these interventions. And then the mentally incompetent, because again, they're unable to give consent or to understand the risk and the benefits that may come about from the study. So this is another big one. Set of patients who you'll rarely see studies being done in, right? Now, that's going to be actual intervention studies. Like if you're looking at randomized controlled trials, you probably won't see a lot of studies like this. Now, does that mean there's no studies being done in these at-risk groups? Well, no. You could have information that maybe you're doing a case control study that's retrospective, and the researchers aren't actually intervening at all. It's just an observational sort of trial. That may be really useful, right? So for instance, if you're wanting to look at risk of spread of COVID-19 in patients who are in, unable to socially distance, right? Maybe prisoners would be a really good group of people to look at retrospectively to see, like, well, what kind of rates did they have versus people that were able to socially distance appropriately, right? So just something to kind of think about in terms of who's the study being done in and who's the type of people that need to be excluded due to the fact that they're at risk. And so you'll typically see that a lot in their exclusion criteria typically. Now, when you're thinking about the Institutional Review Board, who is on that board? Well, typically there's several members that are going to be chairing that, and they include both scientists and also non-scientists. So you may have people who are subject area experts that are participating in it. So you may have, like, if you're doing pediatric studies, or say, for instance, like we do a lot of studies in pediatric patients with oncology diagnoses, because again, we have the Children's Oncology group, and it's a really important group to find out what's the best treatment for these types of cancers. You probably want an oncologist on that IRB to make sure that the studies are looking for justice and beneficence and all of that, right? And also, a really interesting thing that I never thought about prior to learning about IRBs is they actually include members from the community. So you get lay people to come in there, because sometimes it's really easy to get sort of tunnel vision when you have such a scientific sort of mindset, right? So again, you're in school for 27 months and you have this very analytical sort of mindset coming out. Sometimes you lose the forest for the trees a little bit. So it's good to have an outside person to come in and say, wait a second, like, this doesn't sound right at all, right? So sometimes having that extra set of eyes can be very beneficial, and that's a required member to be on that IRB. So if you needed to get IRB approval, which you don't have to, and I'll talk about why in a second for our papers, some of the things you have to do is, one, risk have to be minimized. So make sure that you design the study such that subjects are not going to be put at excessive risk, either due to the interventions that you're performing or due to maybe privacy concerns or things like that. And the risk should be reasonable to the potential benefits. If you're looking at, say, I'm looking to see like a 10%, or 10 millimeter mercury drop in blood pressure, but the risk, there's a 50% risk of death. That doesn't really balance out, right? So those are things they'd be looking for. The selection of subjects has to be equitable, right? So you wouldn't want to say, I'm doing the study and all of a sudden we're going to have just all females in this group and all males in this group and see who does better. Like, unless that's the goal of the study, then that's not really equitable. You want to make sure that there's an equal spread of race, gender, age, if appropriate, all of that into the different groups there. So that's really important. Talking about informed consent, how you're going to be documenting that, how you do data monitoring and security. So actually, how do you handle the data itself and make sure that it is secure and private, and then again getting further into the confidentiality concerns and things like that. So once you show all that in your proposal, they can then look at it and say, hey, we think you should make these changes, or they say you're good to go, or they say, nah, this is not going to work, right? So that's kind of the general flow of the IRB. And you can see here there's different types of reviews that they'll do. So in some cases here you'll find that if you're not doing if there's no human subjects involved, then it doesn't even have to be reviewed by the IRB in the first place. And so you may have a happy face about that because it got a lot easier from that standpoint. Whereas if you were, say, doing something where there's really minimal risk, you may have some exemptions or maybe something like an expedited review, but you still have to submit it to the IRB to see, for them to make that call, right? So for instance, when I was doing a retrospective review of charts, there was no direct human involvement. It was just me looking through a bunch of charts. That was a very minimal risk to any of those people there. We mainly had to talk about privacy concerns and things like that. And so we got an expedited review, right? Very minimal risk. But if you're doing something like an RCT, you're going to need a full board review to actually make sure that that is going to be appropriate. So with your research, most of you are doing literature reviews. That doesn't really meet the definition of original research. You're kind of going through and combing other research that has been done. And so because of that, it does not require IRB approval. But I think it's important to consider if you ever wanted to do this in the future, or if you are ever participating as a provider in a study, something like that. It's good to know sort of this process, so that way you're a little more educated on it. And again, you may find patients who are enrolled in studies or who are maybe candidates to enroll in studies, because you may be working in the ER, you may be working in the oncology clinic, things like that. You may run across these patients. So it's good to have an idea of kind of what's going on in the background. Okay. Anyway, so I wanted to kind of run through a sort of exercise to determine how to design an ethical study, for instance. And so here's an example here. So let's say I wanted to test a new pit viper antivenom. There's actually a new antivenom out in the market now called Antivip, and so this is kind of a good exercise to walk through, because this is kind of what they did there. So the question was like, well, how do you recruit patients for testing this new antivenom, right? Do I go and release a bunch of snakes into, say, a classroom and see who gets bit and then recruit them? Obviously, no, that would not be very ethically sound, right? However, what if you have patients who are already bit by snakes but that were coming to the ER? Well, okay, that's more appropriate, right? Because, okay, I didn't cause them to get bit by a snake. It just was happen chance they did. And now they can come in here, right? And now they can be a part of the study potentially, assuming that they can give consent to be a part of that study. Now, if they were drunk and they decided to handle a snake and got bit, maybe they may not have the mental capability to give consent, right? So these are things you may run into in terms of that. Now, what's your control going to be? Let's say I was doing an RCT and I wanted to randomize patients either into getting the new antivenom, but what's my control group? Do I give them placebo drug? Well, that doesn't really make a lot of sense because I know there are serious risks associated with not treating pit viper envenomation. So I'd have to go with what the gold standard is, or CroFab in the case of the ANAVIP studies, right? And the question is, well, can I randomize patients? In this case, you actually can randomize patients. It makes sense because you could either say, okay, randomly, you're either going to get this drug, or you're going to be getting the gold standard, or you're going to get the new drug out there. And so it's perfectly fine to randomize patients. And then again, that helps to limit a lot of the potential biases and eliminates the influence of outliers and things like that on the study there. And then the question is, well, how do I maintain the blinding? So how do I make sure that the providers don't know what drug the patient's getting, or I don't want the patients to know what drug they're getting? How do I maintain that blinding? And this is actually something where the pharmacy department helps out in this particular type of case, because we actually make sure that the drug that the providers get to give to the patient look identical. So in this case here, they may be two identical bags of saline with a drug in it. They're the same color, the same volume, they're infused the same exact way into the patient. No differences there. There just may be a barcode on there to say, okay, for the pharmacy department to be able to identify which one it is, right? And then you can follow that patient, get the information, and then code that back and figure, okay, well, who did better? Was it the new drug or the old drug, whatever the case may be, right? So maintaining blinding is very important, because if patients know what they're getting, then they may be, there's some psychological effects there with placebo effect. There are a lot of different issues there in terms of introducing bias if you break blindings. That's a really important thing to do as well. So anyway, so just an exercise to consider there. If you have any questions, certainly let me know. I'll be happy to answer them for you. And if I can provide a little bit of, I can want to channel my inner Chidi and Agonye if you're into the good place. Think about ethics. Think about how to treat patients fairly in terms of doing these studies. I think it's a good exercise to think about if you were to design your own study, for instance. So anyway, thanks a lot, and I'll talk to you soon. Bye.